Hello, good evening, good afternoon, and good morning to all our wonderful speakers, chairs, and the audiences in different parts of the world. Welcome back to yet another edition of ACNS Webinars for You. The speaker for the first session of today is our distinguished faculty from the USA, Professor Ali Reza Manzoori. Professor Manzoori is an assistant professor in the Department of Neurosurgery at the Penn State Cancer Institute, Pennsylvania, USA. His clinical interests are focused upon brain cancer trials, surgery of brain tumors, and epilepsy surgery. His literary contributions sum up in scores of international publications and book chapters. We are extremely honored and thankful to him for accepting our invitation to be a speaker at our webinars, and today he will be talking about strategies for proactive management of brain metastasis. The speaker for the second session of today's webinar is our honored guest from China, Professor Yu Yao. Professor Yao is the professor and vice chief glioma services in the Department of Neurosurgery, Huashan Hospital, Fudan University, Shanghai, China. He is also the director of Immunology Laboratory, Neurosurgical Institute of Fudan University. He was the recipient of the Wang Chong Cheng Award of the Young Neurosurgeon 2018 and the Chinese Young Oncologist Scientist Award in 2016. We are extremely honored to have him today at our webinars, and today we'll be talking about MRI pharmacokinetics of convection enhanced delivery in brain. The chair for the session of today's webinar is our distinguished senior faculty from Japan, Professor Akitake Mukasa. Professor Mukasa is the professor and chairman, Department of Neurosurgery, Graduate School of Medical Sciences, Kumamoto University, Japan. His clinical interests are focused upon neuro-oncology, treatment of malignant brain tumors, image-guided surgery, awake surgery, molecular genetics, and biology of brain tumors. He is an integral part of the Japan Neurosurgical Society and Japan Board of Cancer Therapy. He has been rewarded with several awards and honors for his outstanding contribution towards neurosurgery. He is also a noted author with several publications in various peer-reviewed journals. We are extremely thankful to him for accepting our invitation to chair the session of Professor Manzoori. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs and the audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely thankful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Boon Seng from Malaysia is my co-host for today, and with that introduction, I would like to hand over this podium to our first chair, Professor Akitake Mukasa.
Thank you, Raja. So good evening, everybody. I'm Akitake Mukasa from Kumamoto University, Japan. So first speaker will be Professor Ali Manzoori from the Penn State Cancer Institute in the United States. So topic is the brain management of the patient with brain metastasis. So I think that the treatment for brain metastasis has been evolving dramatically recently, partly owing to the advancement of the radiation technique of the local radiation therapy, such as stereotactic radiotherapy and radiosurgery, as well as IMRT. So in addition that now that medical therapy, such as molecular targeted therapy and the drug like immunocheckpoint inhibitor is also now widely used. So such drugs dramatically changed our practice when treatment of the patients. And because of that, molecular targeted therapy is advancing, so the diagnosis is also important. And I think that the liquid biopsy is more frequently used for the treatment of brain tumors. So today we are very excited to hear that such various advanced management technique of brain metastasis from Professor Manzoori. So could you please start the lecture?
Absolutely. Thank you very much, Professor Mukasa, for the introduction. And that's a great point that you mentioned in terms of the advances in brain metastases. So the objectives for today's talk will broadly be summarizing the current management of brain metastases, and then followed by talking about the roots of cancer metastasis to the brain as far as we understand them right now. And that'll segue into CSF-based diagnostic signatures in brain metastases. And I'll bring all of that together to provide a rationale for integration of CSF-based diagnostics and potentially therapeutics into clinical practice. So as we all know, brain metastases are the most common adult brain cancer. The frequency is rising, likely as a result of improved systemic treatments. People are living longer. The prognosis is poor, but getting better. And we have great local therapies, but there's still morbidity associated with them. So what are these therapeutic options? So surgery is still reserved for patients with very large tumors, those who have neurological deficits, or in cases where the diagnosis is not clear. Radiosurgery, as Professor Mukasa mentioned, is becoming very popular, particularly with asymptomatic and small brain metastases. There's still a place for whole brain radiation therapy for patients with numerous brain metastases, those with a poor performance status, or certain histologies such as small cell lung cancer. We have other local therapeutic and systemic therapeutic options as well. Now, when it comes to systemic therapy, chemotherapy has been the backbone of it, but now more and more we're developing hormone therapy, targeted therapy, and immunotherapy, and a combination thereof. So what is the efficacy of these systemic treatments against brain metastases themselves? Nowadays, our target therapies, for example, the third generation tyrosine kinase inhibitors have improved blood-brain barrier penetration, and also immunotherapies are starting to make a splash in this field. So we were first interested in looking at a combination therapy for brain metastases. And the way we went about this was using a network meta-analysis focused on non-small cell lung cancer in patients without an EGFR or a mutation or an ALK rearrangement. And network meta-analysis, for those who may not be familiar, is a great methodology for quantitatively comparing A versus C when there is no head-to-head trials and one is simply not feasible, as long as you have an intervening intervention that has compared them, so A versus B and B versus C. So in this case, that's exactly what we did, and we looked at overall survival and progression-free survival. You can see, no surprise, chemotherapy was the node that was shared among all the various studies, and you can see the branches of the different therapeutic options. And we can see that from an overall survival perspective, immunotherapy plus platinum-based chemotherapy had superior survival compared to chemotherapy alone, as did other combinations of immunotherapy. From a progression-free survival, less studies, but similarly, in the addition of immunotherapy had an impact on progression-free survival as well. Now, none of these studies looked at intracranial progression-free survival, and none of them reported in a meaningful way death from neurological cause. So indeed, they are extending patient survival, but what are they doing against the brain metastases themselves? That's why I was particularly excited about this study, which came out, I think, 2 to 3 years ago in the New England Journal of Medicine. And we know for the longest time that the combination of ipi-nivo immunotherapy has made a big impact on patients with advanced melanoma. This study was interested in looking at this combination in patients who had developed small and asymptomatic brain metastasis from a melanoma primary. And what's interesting here, you can see that a decent proportion of patients did not have a high PD-L1 count. So that should not necessarily be a deterrent. And you can see here, based on this table, that a relatively high proportion of patients did derive a meaningful clinical benefit from an intracranial response, approximately 57% of the patients. So focusing on these patients, here's a swimmer's plot. And you can see this blue line is while patients are still on therapy, and that refers to the combined 4 cycles of ipi and nivo. And red lines refer to either just on nivo maintenance alone or off of immunotherapy completely. The open circle indicates a first response of the brain metastatic lesion or lesions to the treatment. And you can see that the majority of them did respond within the first 8 weeks. So this builds the case that if you have a small asymptomatic brain metastasis from advanced melanoma, you're going to put the patients on combined ipi-nivo anyways. Why don't we give it 8 weeks, spare them SRS, and see if there's a response? If there's no response, then you can proceed with SRS. So that's a very exciting study in terms of preserving our local therapeutic options and thus limiting the morbidity potentially associated with them. Then we're interested in looking at the real world differences in survival after the institution of combined immunotherapy in patients with melanoma brain metastasis. And for this, we use the SEER database, which is the Surveillance Epidemiology and End Results Database, a US national database. It has its limitations, but it's great for looking at epidemiology and for various diagnoses and survival. And you can see that prior to the approval of any immunotherapy, compared to the post-combination immunotherapy approval era, there was a significant increase in 1 year, 2-year, and median overall survival. Again, this is just looking at overall survival of the patients, not looking at anything in the brain. So then we're interested in asking the question whether or not immune checkpoint inhibitors can have any role in prevention of brain metastases. This was a combined study. We're looking at VEGF inhibitors and immune checkpoint inhibitors. But bottom line was we were looking at systemic cancer patients who were undergoing a study that either had VEGF inhibitors or immune checkpoint inhibitors as a key part of the intervention. And they looked at brain metastasis, or at least brain imaging, at baseline and at the conclusion of study, thus giving us the opportunity to study the rate of either new primary brain metastasis or secondary recurrence of brain metastasis. Taking this strategy, we found about 7 or 8 studies that had immune checkpoint inhibitors. They were all melanoma studies. All of them had radiosurgery, but one arm was radiosurgery plus immune checkpoint inhibition. The other one was radiosurgery alone. And you can see that in patients getting radiosurgery and immune checkpoint inhibition, there was a 35% relative risk reduction of secondary brain metastasis development. So this gives potentially, again, the hint that immunotherapy not only may be good at treating small brain metastases, but perhaps even preventing the development of new ones. So again, we leveraged the publicly available databases. And for this one, we looked at the Trinetics Database. It's a combination of a network of cancer centers or institutions that are combining their electronic medical record data. There's about 50 or 60 institutions and have about 89 million patient encounters on them. It's great because you can look at specific diagnosis in a time-based fashion. So patient has advanced melanoma, then they go on to develop brain metastases, and you can sort them by the drugs that they're on. So here we looked at patients with advanced melanoma who went on to then develop brain metastasis prior with not being on any of AP or Nivo in this column, patients with being on AP alone, or patients on AP and Nivo. And you can see in the pre-immunotherapy era without AP and Nivo, 1.5% only had brain metastasis. Now, there's a caveat associated with that because that data goes as far back as the 1980s, where perhaps imaging wasn't as good, or perhaps patients were simply just not living long enough to develop brain metastases. So I want to draw your attention to these columns instead. In patients with AP alone, the rate of new brain metastasis development was 15.6%, whereas in the post-combination era, the rate of new brain metastasis was 9.6%. And that was a statistically significant reduction in the rate of new brain metastasis. So the bottom line here is that immunotherapy can perhaps be one of the agents that can be leveraged in the proactive management of brain metastasis. We know it improves survival of brain metastasis patients in general. It can be a therapeutic option against small brain metastasis, at least from melanoma, and it may have a preventative role. So now let's switch gears to talk about the roots of cancer metastasis to the brain. Traditionally, for the longest time, we've talked about the dissemination of brain cancer through a hematogenous route. So cancer cells locally build up to a high enough concentration, they extravasate into the blood vessel, they seed their target, eventually they are able to build a favorable environment for themselves for proliferation, and that is how they get into the brain. But can there be any other potential routes to the brain? So the blood-brain barrier is a formidable one. It has evolved over thousands or million years of evolution to protect our brain from the systemic circulation. And also, it is not uncommon to see repeated central nervous system relapse in the setting of controlled systemic disease. So why could that be? So learning lessons from central nervous system leukemia or lymphoma, we can derive some potential hypotheses. So for a very long time, we have known that a high proportion of patients with ALL who respond to systemic treatment develop CNS disease. And the original thought, similar to our current hypothesis for solid cancers, was that this was the root of hematogenous route was the way that these cancers were getting in and hiding from systemic treatments and eventually coming back out. And the CNS being a sanctuary for systemic tumors is not isolated to just the hematogenous cancers. We're seeing more and more reports of, for example, testicular cancer and even non-small cell lung cancer. But it's important to note that there's multiple routes of entry to the intracranial system that avoid the blood-brain barrier. And namely, ever since the discovery in 2015 that we have lymphatic channels in the brain and they run along these perisinusoidal veins, that has been revolutionary. And you can see that they can very easily get into the subarachnoid space, into the CSF, and we also have the blood CSF barrier here as well. So there's other potential routes of entry of cancer cells getting into the brain other than the hematogenous route. And here's a very nice study. Again, it's an old one, but from children with leukemia. It was an autopsy study that looked at the brains of 126 patients, 70 of them having arachnoid leukemia at the time of autopsy. And they're able to show that patients with early brain disease we were able to see the disease only along the deep arachnoid layers. And in patients with advanced disease, only in that case were we starting to see tumor in the pioglial membrane. So again, building on the case that perhaps these cancers are infiltrating from these lymphatic channels and then spreading out, so from the CSF and then getting into the brain. And again, this makes sense. The CSF is rich in nutrients and it's relatively spared from immune surveillance. You can make the argument that yes, it's rich in nutrients, but it is not highly vascularized. So how do these tumors survive? Like most other situations, tumors can adapt to their environment, and you can see that the upregulation of VEGF and creation of microvasculature is nothing new. We've seen it in all cancers, ALL, and other leukemias as well. So then we went back again to primary data. Can the CSF be an actual route of dissemination? So we looked at retrospectively the MRI of patients, 204 patients with new brain metastases, no leptomeningeal disease. And they were signed up for stereotactic radiosurgery. 66 of them consented to us drawing CSF from them via lumbar puncture prior to their gamma knife. The male-female ratio was 1:1, average age was 64, and the majority of the patients had a lung primary. And here you can see that we had a total of 927 brain metastases for an average of 4.6 per patient. The majority were less than 5 centimeters, and 3.9 of the lesions, or 85%, were in contact with the CSF space. Not, we classically think of the gray-white junction, but we wanted to look at whether or not there's contact with the CSF space, and 85% of them did contact that. And then we looked at positive cytology, again, emphasizing that these are patients without leptomeningeal disease. And you can see with increasing burden of disease, the proportion of patients with positive cytology grew. So yes, you can make the case that these tumor cells are shedding into the CSF rather than using the CSF as a route of entry. But this is also another hypothesis to entertain. Currently, it's CSF in neuro-oncology, and it's used for diagnostic purposes for central nervous system lymphoma and leptomeningeal disease, from a prognostic perspective for medulloblastoma and germ cell tumors, and therapeutically, we use intraventricular delivery or intrathecal delivery of therapeutics in central nervous system lymphoma, medulloblastoma, and some patients with leptomeningeal disease. There's currently no role in diagnosis and management of brain metastases otherwise for CSF. So going back to the current management guidelines of brain metastases, when it comes to screening, at least in North America, we have the NCCN guidelines for stage 4 non-small cell lung cancer and small cell lung cancer. If you have this patient, you should do a baseline brain MRI regardless of the symptoms. And to do that, we have the contrast enhanced brain MRIs. We have brain sampling to get an idea of the molecular markers are, but nonetheless, we often choose our therapeutic based on the molecular markers of the systemic cancer. And a treatment, as we talked about before, is comprised of local therapies and in combination with systemic therapies. And after that, we monitor them with contrast enhanced brain MRI. But there are challenges in the current management schema. So for example, we know that triple negative breast cancer and HER2 positive breast cancer do have a high propensity to metastasize to the brain, but there are currently no NCCN guidelines for screening them at baseline. And from a brain sampling perspective, it's relatively minimally invasive, but nonetheless still has morbidity. And selecting our treatments based on the systemic cancer assumes that the mutational profile of the brain metastasis is similar to the systemic cancer. But I love this, I think 2015 study that looked at matched tumor patients with systemic cancer and brain metastatic cancer that did have molecular profiling. And you can see that in more than half the cases, the brain metastatic lesion had an actionable molecular mutation that was different from systemic cancer. So in potentially half of the cases, we're not using the correct targeted treatment when we were basing it based on the systemic cancer. And then when it comes to monitoring, MRIs are great, but they can't necessarily pick up micrometastases or early recurrence. We still have the challenge of differentiating radiation necrosis from true tumor recurrence. And for how long do we follow them? So typically right now, after gamma knife, we follow them with brain MRI every 2 to 3 months. And after 1 year, if there's no recurrence, then we don't really follow them. Can we leverage the CSF for improving diagnosis and surveillance? We don't want to wait until it's too late or we lose that window of opportunity. I think CSF is an ideal liquid biopsy matrix when it comes to brain lesions. It's an ultrafiltrative blood, so we don't have all the blood proteins, and it's in direct contact with the tumors. And we are using it right now, as I mentioned before, but even in leptomeningeal disease, the sensitivity of a simple lumbar puncture is only 50%. We need to get a little bit deeper. We need to look at the transcriptomics, genomics, and proteomics. And DNA, RNA level alterations alone do not predict protein activity. And so it's hard to know the tumor phenotype and actually develop targeted therapeutics against them. So to do that, I think we need proteomic analysis. And so as a proof of concept, we looked at our own biorepositories at Penn State. Because of our intrathecal chemotherapy program, we have one of the largest clinically annotated banks of CSF in patients with brain tumors. And we took 20 patients with NPH, normal pressure hydrocephalus, as a non-tumor control, 22 with GBM, 17 with brain metastases, predominantly lung, and 14 with non-small cell central nervous system lymphoma. And we used the MSTERN protocol for sample preparation. And using this, we're able to use as little as 35 microliters of CSF to derive some meaningful proteomic studies. This is just a table of patient characteristics. I won't bore you with the details. But so this is how we performed our analysis. So we used the publicly available enrichment analysis for a pathway level determination and standard statistical modeling such as logistic regression and comparing models with area under the receiving operating curve to assess the performance of our diagnostic models. Based on the peptides and proteins that we were able to detect, we looked at the commonly shared malignant proteins between GBM, brain mets, and central nervous system lymphoma to derive our malignancy signature. And we also looked at the commonly shared non-malignant proteins to derive our non-malignancy signature. So question one was, can CSF in a patient with an intraaxial lesion be used to differentiate from this being a malignant pathology or non-malignant? After we developed our signature, we validated with external cohort of brain tumor patients and also publicly available data on proteomics of patients with non-tumor CNS pathology, such as Alzheimer's, ALS, and MS. And you can see that the malignant signature was much higher in tumors and not so detected in non-malignant pathologies, and similar with our non-malignant signatures, much lower in tumors and normal range in the non-malignant pathology. And from a diagnostic performance perspective, obviously high performance in our internal validation, but also relatively good performance in our external validation of a recent cohort of GBM patients with CSF. You can see sensitivity of 74% and specificity of 88%. So then, now that we know we can differentiate malignancy from non-malignancy, can we tell apart these tumors themselves? And we wanted to have a clinically meaningful and relevant approach. So we looked at the top proteins that were detected in each tumor sample. And so we can see here, GAP43 was the most commonly detected one in GBM, TFF3 most commonly detected in brain mets, and CACNA2D2 in lymphoma. And taking each alone, so if you're positive for GAP43, what are the chances you're a GBM? The performance was good, but not that great. So instead, we performed a triplex classifier. So you have a CSF sample. It's positive for GAP43, but negative for TFF3 and CACNA2D2. Is that a GBM? So yes, you can tell with a sensitivity of 73% and specificity of 87% whether that is a GBM or not. So summary, as little as 35 microliters, you have these three peptides that one day we can, once validated, we can develop an ELISA assay for, so any clinical laboratory can do it, and that gives us the opportunity to differentiate between these three different tumor entities. From a prognostic perspective, our sample size wasn't large enough to find any individual biomarkers, but from an overall pathway analysis, we were able to validate what we already know in the literature. So high blood coagulation profile, high angiogenesis, and high stemness as an overall poor survival. So obviously there's limitations associated with this. We only looked at free peptides. We didn't look at proteins in EVs or on cell surface membrane proteins. We had ultra-long GBM survivors, median overall survival greater than 2,200 days. Again, a function of our intrathecal chemotherapy program. These are heavily pretreated patients. The novel biomarkers, the GAP43, CACNA2D2, et cetera, were not externally validated because the Schmidt cohort that I mentioned did not detect these. And obviously, we didn't account for alternate splice sites, post-translation modifications, and other omic analyses. So our next steps that we are undertaking right now is prospective validation of these markers. We need preoperative and longitudinal sampling because, again, these were heavily pretreated patients, and we need to develop assays to confirm our targets. So this is parallel reaction monitoring assays. And once that is confirmed, then we can go on to develop ELISAs. And then ultimately, proteomics is great, but we need to integrate it with other omic analysis, including studying extracellular vesicles and even cell-based assays. So with that, can we envision a more central role for the CSF in neuro-oncology? So from a research angle, you have this patient with an imaging abnormality. As long as it is safe, we can harvest CSF and blood prior to any manipulation or any treatment, perform proteogenomic analysis on them, and develop signatures that are diagnostic or prognostic and validate them. And then they undergo their local therapy. And during the course of adjuvant therapy, let's say you reach this stage of minimal residual disease, can we profile the CSF in that scenario to see if there's any residual subpopulation of treatment-resistant cells that will see the inevitable recurrence? Or when you have a case of imaging ambiguity, is it radiation necrosis or true tumor recurrence? Can we develop signatures that can reliably differentiate between the two of them, so patients who do not get unnecessary surgery or they don't get the surgery that they need too late? And hopefully we can eliminate that tumor recurrence part. And from a clinical perspective, can we use CSF at time of diagnosis for high-risk systemic cancer? So for example, I mentioned patients with stage 4 non-small cell lung cancer or small cell lung cancer itself. So how do we define high-risk status? We have the established criteria, as I mentioned, but they're also nowadays coming out with AI algorithms, such as the Caris molecular profiling platform that looks at the molecular profile, whole exome and whole transcriptome sequence of the primary tumor. And based on that, they predict a 2-year, 3-year risk of brain metastasis development. And then we can combine it with other analyses. It could conduct other analyses, such as circulating tumor DNA, proteomics, and cell-based assays, to see if there's any signal that we can detect very early on prior to any established brain metastasis, or whether or not there's a chance that there's seeding going on, or at least shedding going on from micrometastasis in the CSF. And then let's say you do have a patient that has been diagnosed, we've done the CSF for diagnostic. Why don't we go ahead and be bold and talk about inserting an Ommaya reservoir? Obviously, there's safety considerations. But so in addition to the standard of care local therapy, we can consider intraventricular tumor-directed therapy and leverage that. In addition to imaging surveillance, perhaps we can surveil the CSF as well and develop signatures that can tell us an early signal of tumor recurrence or alteration of the mutation profile of the tumor, so that we can more proactively manage them. There's concern, as I mentioned, there's lots of complications with Ommaya reservoir placement. Misplacement is the most commonly cited concern. It can be up to 25% in the literature. And as I mentioned here at Penn State, we have a very heavy intraventricular chemotherapy program. So we have a lot of these, and we've improved the placement with navigation and use of endoscopy, so you can confirm that you're indeed right at the foramen Monroe. There's concern about hemorrhage and there's concern about infection. It makes sense to be concerned about infection. It is at the end of the day a foreign body. We're repeatedly accessing it, and these are immunocompromised patients. And looking at the literature, infection is a very common complication. It can be 2 to 12% of patients, and the treatment is controversial. Because of how much we rely on this reservoir for intraventricular therapy, we wanted to know if it's possible to not remove it. And so we've instituted this treatment pathway of 2 to 3 weeks of rifampin oral, intraventricular vancomycin and IV antibiotics directed at the particular bug. And using the strategy, we've been able to clear 73% of the infections without removing the catheter. So again, why don't we take a more prophylactic approach? So we instituted a quality care protocol to co-administer 10 milligrams of vancomycin with each treatment cycle. And we want to study the rate of infection. Infection is defined as 2 consecutive positive CSF cultures of the same organism, or 1 positive CSF culture and clinical or laboratory signs of infection. We studied a 6-month period after starting this protocol. We had 39 patients undergo intraventricular chemotherapy for a total of 274 treatment cycles. Our infection rate was 0%, and there was no treatment-associated toxicity. To compare that, the preceding 5 years before instituting this protocol, we had an infection rate of 1.7% in a total of 1,932 treatment cycles. So that translates to an absolute risk reduction of 10.3% and a number needed to treat of 10. And the number of access points, treatment cycles, was the only covariate affecting the infection risk. From a health economic perspective, per dose, vancomycin only costs $10. So if you, over the 6-month period, that would have been $2,740. But if you calculate the cost of managing one infection with the antibiotic protocol that I mentioned, or possibly undergoing surgery, that's about $88,000 in our system. So based on the 1.71% infection rate, if we project 4 infections over the same 6-month period, that's a cost saving of $350,000 almost. So the bottom line is we need to push the envelope. We're making great strides, but still not quite there. We need a multidisciplinary approach of neurosurgeons, neuro-oncologists, radiation oncologists to take this proactive approach. And we need a little bit more creative science. Thank you very much for your attention.
Thank you very much for your very interesting talk. So, and tonight we can hear the treatment of melanoma, immunotherapy, and the metastatic brain root, and also the method of CSF diagnosis. I have CSF diagnosis method is very, I think it's very interesting. So do you use that CSF collection routinely in your practice, or just for the research purpose?
So currently it's just for research. We do use this for the intraventricular chemotherapy patients. We look at the cytology of it to see how they're responding to treatment. But the proteomic stuff, obviously, no, we're not doing it in terms of clinical. It's still at the research basis.
So you show that like 20 or 30 brain met patients that you analyzed. So are those patients the patient treated with intraventricular chemotherapy?
Yes.
So
yeah. Go ahead.
So what about in the case that only the small brain metastasis is present? So can you also detect the TFF3 in the case of brain metastasis very effectively, or how about that?
Yeah, that's a great question. I think the sample size has got too small to be looking at the volumetric correlation. But one thing that we did see, that the protein number of peptides detected did not correlate with the size, the volume of the tumor, or actually even contact with the ventricle or major CSF cister. But definitely we need to see if the greater the tumor burden, the higher likelihood that we're going to find these specific peptides. That's a great point.
Probably I missed your presentation. So what's the method of your proteomics? Is that mass spectrometry or?
Mass spectrometry, yes.
Do you also check the ctDNA, the other than proteomics? Do you also check the DNA or RNA or other the nucleotide to see the correlation or whether the protein mix is better or the circulating DNA is more sensitive. Do you check the DNA as well?
Not in the study, and that is not a focus of my lab, but with collaborations, we did look at methylated DNA immunoprecipitation. And that has also some promising diagnostic signatures. It's much more challenging to look at methylated DNA, as you can imagine the method. And so far, again, from a bioinformatic perspective, we're working on correlating the methylated DNA with proteomics, but that's a little bit more laborious.
Right. We would take questions from the audiences, but one thing that I would like to mention is one of our honorable speakers from China presented about IDH1 mutation detected in through mass spectroscopy, and it was like within 5 to 10 minutes you will get the results, and it was wonderful to see that. I hope your level of proteomics is more advanced, and we are all eagerly waiting to learn from you. Professor Selfie Oswari from Indonesia is here. Dr. Selfie, would you like to ask your questions? She has, of course, mailed me her questions because she is going to wash for a case. So I'll just read out her questions, like using immunotherapy as the first treatment in brain mets to postpone or avoid SRS. What kind of brain mets would be suitable for that? And has it been a protocol in your institution? And is there any specific molecular investigation prior to the decision?
So we don't use that yet. I don't think it's FDA approved yet for treating brain metastases. I'm wondering if at MD Anderson they're doing that, because this study was out of MD Anderson. But as you saw in that table 1, if one day we're going to have this clinically instituted, the PD-L1 didn't make that much of a difference in the PD-L1 expression of the primary tumor again, but we also made the case that the profile of the brain metastatic lesion may be different. I think obviously there's concern of instituting immunotherapy if someone's actively seeding brain and you had 2 small ones, but those 2 small ones grew after 8 weeks and you developed some new ones. Did you potentially miss a window? I don't know, but it's still in its early phases. So as I mentioned, we don't use it. It's exciting, needs to be studied more. But I wouldn't jump the gun to immediately just skip radiosurgery.
I hope Dr. Selfie has her answers. One more thing I would like to ask is about, as you mentioned, spectroscopy. There has been great deal of in this field whether of using Raman spectroscopy for the detection of malignant cells. So, have you ever had any experience in this field?
No.
No. Okay, right. Thank you very much. My co-host Liubun Singh, any questions from your side?
Thanks, Raja. Thanks, Professor Alizera, for a very nice presentation. I would go to a more basic question, Professor, if you don't mind. May I know that, as we know that for systemic spread to the brain by the extracranial cancer in actual sense is very high, but the current routine in staging the tumor for extracranial cancer, usually MRI brain and spine are excluded in most of the workup. And in your opinion now, especially for lung CA and breast CA, do you think that routine MRI brain or CSF study should be part of the protocol? Because now we only do MRI brain or CT brain in symptomatic patient rather than a routine screening. My first question. My second question, Professor, in your institution for newly diagnosed brain metastasis, in symptomatic patient, especially just via CT brain, who are the primary team in your institution we manage this patient? Because as you can know that majority of brain mets patient doesn't require any cranial surgery and also even a CSF diversion procedure. So that do you think that there should be a specific team to manage this, especially a newly diagnosed and we still do not know where is the primary? My last question, Professor, in CSF diversion procedure, those with hydrocephalus and brain metastasis, do you need to actually pre-warn a patient that there is a high risk of the CSF seedling into a peritoneal cavity in your patient? Thank you, Professor.
Thank you very much for these great questions. I'll hopefully can remember all three of them. But so number one, I think with the tumors that we know are high risk to go to the brain, so such as triple negative, even advanced melanoma, or HER2 positive breast cancer, at least the baseline MRI would be a good idea at the time of diagnosis to establish that. And I definitely think especially through this presentation, I've made the case that especially if we've done that MRI to show that there's no concerning mass effect, CSF should be considered. You know, if it's still in this infancy, still in research phase, but I think it has a true potential, and it's a minimally invasive diagnostic that is not clouded by all the different blood markers, and you don't have to enter the brain. So that whole theoretical risk of seeding. So I think we should keep pushing the envelope when it comes to CSF, and I think perhaps the guidelines need to be revised to have a little bit more of a push for baseline brain imaging. Your second question was about the teams that are managing it. So I think it's important to consolidate care. You know, that they need to be managed at academic institutions in a multidisciplinary fashion. So right now, if they need surgery, obviously they come through the door with neurosurgery. If they don't need surgery, and gamma knife radiosurgery is the way to do it. We work very closely with our radiation oncologists, and we do the plans together. We place the gamma frame and the frame and plan the patients together, and either radiation oncology or neurosurgery follows them. Often, if there's no concern, radiation oncology just follows them until something else needs to be done. Having said that, it's important to get out there in the community and spread the evidence that, you know, whole brain radiation therapy is slowly falling out of favor. We can do gamma knife for more and more number of lesions or volumes now that the fractionation, etc. So we institute tumor boards, brain tumor boards in the community as well with our oncology partners, and we want to engage them as well. And then lastly, were you referring to shunting a patient and seeding the peritoneal cavity?
Yes, Professor.
Yeah, that's a great point, right? Like if we're making the argument that the tumor cells are there, it's a realistic possibility. We do try to tell the patients about that possibility, but could you also make the case that it's past the blood-brain barrier, it has better access to the systemic treatments that we give them have better access to these lesions? I personally have not, obviously the rate of shunted patients with brain metastases are low, and perhaps they're not living long enough after getting to that point, but I personally have not seen seeding. I would love to know if you have seen any, or Professor Mukasa or anybody else. I have not seen it yet.
Thank you, Professor.
Thank you very much. I think it was a wonderful lecture, and we learned a lot today from you. Thank you very much, Professor Manjuri, and thank you very much, Professor Mukasa, for chairing the session. Professor Shubin is still here. Professor Shubin, any comments from your side?
Yes. Actually, Professor Manjuri, you mentioned the infection rate. Actually, I'm interested. How about how is your opinion about the Neuralink chips in implantation?
Chips?
Actually, yes, the Neuralink. You know, the Elon Musk.
Yeah.
There's some commercial promotion, but I think it's quite dangerous.
Yeah, I mean, it's starting to get into the realm of sci-fi, right? But I think it'd be cool, but also scary.
Yeah.
Right. So thank you very much. If Professor Shubin can update us regarding the number of people.
Yeah, today about 600 people, audience in the WeChat channel. Thank you.
That's a great number. Thank you very much, Professor Shubin, for broadcasting this. So we'll move on to the second session. Professor Mukasa, would you be staying back? I understand Professor Manjuri has to go. Professor Mukasa, would you be staying back for the second lecture, please?
Okay, so
Right.
next lecture will be the Professor Yu Yao.
It's my honor to present here, and my lecture is about MMI-based pharmacokinetics of convection enhanced delivery in brain. As you know, glioma is the most common primary malignant brain tumor, and the standard protocol for treatment glioma, including surgical resection, adjuvant radiotherapy, and chemotherapy. And in recent years, in China, tumor treating field is used to Chinese people, but the glioma will finally recurrent. And as we know, for chemotherapy, such like temozolomide, only about 20% temozolomide will go through the blood-brain barrier. That means cross the BBB. So only 20%. So we need another technique named CAD, caster-based technique. As shown in this picture, for the temozolomide, if we go into the vascular, only 20% can cross the BBB. But if we use the CAD like this, set the caster to the region in the brain, we can take the drugs directly to the brain. There are some ways to overcome the BBB, including control resist system like Gladio. We know the advantage of Gladio can cross the BBB and release slowly over the prolonged period of time. But there are also disadvantages like limited drug loading capacity, poor drug distribution, the complications such as seizure edema can see the clinical setting. Also, we found in the lecture that recurrent glioma is not work from the Gladio. The other way is a nanomaterial system. They have high surface to volume ratio and promotes diffusion through the BBB, but poor control accumulate and distribution, and poor understood. And there are third way, focus ultrasound. Ultrasound guide transmitted over the BBB, low systemic exposure, but they also called edema and unconscious thermal injury. So if the lesion is located in the perisoma region, we use drug to go into for neurosurgical technique. We can use the interventricular infusion, just like Omaya, or the intracellular injection. The drug will go into the ventricular, but ventricular cross the brain. They need to face another barrier, such names interstitial fluid barrier. The typical ways is like temozolomide going to the vascular, and they need to cross the BBB. So CAD can cast the caster directly to the lesion. So what means convection? And what's the difference between the diffusion? The diffusion, if the caster, the drug initiate here, and they can get diffusion. But if we use a pump, we can get a much longer range that causes convection. The famous poster in the snow 2 years ago, we can find in the recurrent glioma a lot of drug. For temozolomide, only get 4.4 months for overall survival. And that's a Gladio, that's a TTF, lomustine, Avastin, and lovastin plus Avastin. But you can see here, when targeted to IL-4 receptor, use CED technique, they can get a much longer overall survival. But for the drug clinical trial, we know the phase one clinical trial, we need to get PK and PD and the MTD dose. If three case is no toxicity, we then go the next high dose. One toxicity at 3 case on the same dose, and 2 and more toxicity, the MTD is decided. But if the drug going to the brain, how we use the phase 1 trial and the clinical trial to determine the exactly diagnose. So like the clinical trial compare with IL-13 and Gladio, they do not have very successful data. One reason I think is the people cannot know the right dose for IL-3 in the brain. So CED compartments including intracranial theater, connecting tube, and infusion pump, they can cross the BBB, large volume of distribution, and low system exposed, but lack of pharmacokinetic and local concentration study, even like this famous study, and the lack of actual microscopic study, and they also face risk of ventricular leakage. So what we want to do is to set up a system to find the pharmacokinetics and the drug concentration, use MRI scan. We first transfer signal intensity to T1 relaxation time. We use this formula. We use T1 relaxation time and T1.0 relaxation time. And we know the relaxation and we can calculate the concentration. All this is processed by the micro lab. So T1 relaxivity, and we set up a hydroplanto experiment. We use T1 relaxivity of gadolinium and CED infusion of the hydroplan and the distribution parameter, and scan and determine the gadolinium use MATLAB. We set up different concentration of gadolinium, like 1.4 and 1.8, and increase the dose. Then all the dose can scan by MRI scan. Then we get T1 mapping. We found the T1 and set up the curve between the T1 and the signal intensity. And we use this formula to calculate the gadolinium relaxivity is 3.9. Also, in the hydroplanton, we can calculate the volume of distribution calculated by the equation of Flamsteed-Kohn, and volume of infusion displayed by the micro infusion pump. When the times go on, we can see the center will decrease and the femur will increase. That will show here. If this is the infusion site, then with the time after the infusion, the 3 mm away from the center and the 6 mm away from the center, you can find the 6 mm will increase the concentration and the center will decrease. That means the drug go away from the infusion site. And we also test this theory in the rat brain. Also the familiar procedure. You can see this is a columnar sagittal and horizontal image SL3 distribution for the gadolinium with transferred by the CED protocol. We can see the VD versus VI is more than 4, 6, 7, 6, and 4. That means the gadolinium can can pass away from the infusion site. And before the infusion, this is before infusion, the T1 and T1 mapping and the concentration mapping. You can see follow the time goes on and the central is decreased and peripheral increase the concentration. The central will decrease the concentration and the peripheral will increase. That means drug go away. This is the red 2 and this is red 3. So the other very important question is how about if the drug is going to the ventricular or if the drug leakage to the ventricular. We then set up a model. This is before the infusion and this is post the infusion. We use CED to put the gadolinium to the ventricular. For the non-living state, as you note, for the non-living state, the gadolinium only distribute in the brain ventricular due to the absence of metabolism. But in the living state, after intraventricular administration, gadolinium was mainly distributed in the subarachnoid space and did not enter to the parenchyma. That means if you want to treatment a glioma, use ventricular and use puncture, that it did not work. And this pharmacokinetics and intraventricular CED infusion in the living state. The drugs was mainly in the subarachnoid phase in the concentration mapping. And after 6 minutes, the drug is almost invisible. So the conclusion, we develop a method of determining of drug concentration in CED study based on the T1 mapping, and approve of concentration study showed the pharmacokinetics and characteristics of CED in the hydroplane and rat brain. The future direction, including the gadolinium in vivo to determine accurately the concentration determined in vivo to be verified, and misplaced of catheter and leakage infused along the catheter into the ventricular. We need to set up a glioma animal model and evaluate the temozolomide through the CED. And we also want to know the actual microscopic study relationship between the CED and the transmembrane transport. And we also have some preliminary data. For this is a control, and this is infused with CED. You can see increased fluid content in the cytoplasm and no segments damage to the organelles. And this is control in this infused. Normal synaptic structure, no widening of synaptic cleft, and very little loosening of fibers. That means the CED will not damage the DTI or fiber tracking. So it's my honor to present here, and thank you, Dr. Chu, for inviting me here. Thank you.
Thank you very much, Professor Yu Yao. Professor Mukasa, any comments from your side?
Thank you very much for your beautiful lecture. So, and nicely show the diffusion of the gadolinium into the rat brain. So, I have a few questions. So, you use the gadolinium to monitor the infusion and diffusion in the brain. So when you use the temozolomide or other chemotherapeutic drugs, so the state of diffusion is similar or different, because probably the drug and the gadolinium, the molecular weight and other factors are different. So do you have any idea for that?
Okay, that's a very interesting question. We just use gadolinium to present the pharmacokinetics. If we use, in the future, we use temozolomide, we can mix the gadolinium with temozolomide through CED. And if we use very large, very large volume of drug like antibody, it will not cause the BBB. We do not use the gadolinium. We need to use another drug to label to the antibody. So that's the difference. So we just do very preliminary data, because it is, I think it is very important, because for more than 10 years, a lot of CED clinical trial is performed, but nobody calculates the exactly drug dose in the brain. So I don't think the negative result of the CED trial is reasonable, because the drug dose may be too low or maybe too high to the brain.
So when you check the diffusion of drugs, so you mix the gadolinium and drugs and then inject into the brain. Is that your future direction to check the?
Actually, I think the second step for me to study, I want to infusion not temozolomide, not just the temozolomide. We want to infuse the T cell. We want to infuse the T cell through the CED. I think that T cell is more useful, just like Professor talked about the metastasis, they use immunotherapy. So we want to use to pass the T cell through the CED to the brain to treatment the glioma.
So may I ask another question? So in the for the treatment of the brain tumor like glioblastoma, so the diffusion rate might be different from the case when you inject it into the normal brain, because there's a tumor cells and also the edema. So the diffusion may be very different from what you showed today in the normal rat brain. So do you think any difference?
Yes, that's a very, very good question. We just put the CED to the normal rat brain, and not to the edema, not to the edema, the malignant brain tumor. But I think for the clinical trial, clinical setting, we use biopsy. We use biopsy to get the tissue from the deep brain tumor. They will do not cause the damage to the fiber, and they will do not cause the edema, the further edema, but except you cause the hematoma during the biopsy. So I think the CED tube is very thin, and when it is guided in the MRI guide, you do not will get the firmer edema.
Okay, thank you.
Okay, I have a question, Professor Yao. Thank you very much for your very interesting presentation. And I think it has to be some future future. But you mentioned that you will use some T cell to inject into the local parenchyma. Do you worry about some abscesses? Because you know the local high density of the T cell maybe form some abscesses.
You know, abscess or the
yeah.
I want to use the tube. Actually, I want to use tube. The T cell from the tumor, because
a tumor. Okay.
The Rosenberg, you know, the famous scientist and the clinic in the NIH, we use a tube to that will cause very good result to treat the solid tumor. So we have finished a phase 1 clinical trial with tube to treatment the glioma. So the next in the animal model, I will first to test so separate the tube from the glioma. Then through the CED to injection to the tumor cavity. But there are a lot of way to go, I think. But that is interesting.
So it's the cell harvested from the patient himself, or from just other?
From tissue, from glioma tissue.
Oh, from glioma tissue. So this is after the resection or some biopsy.
Yeah. Okay. You know, the T cell can be cultured grow very quickly, more than tumor cell.
So it's harvested from the patients themselves.
Yeah, from the tissue.
Okay, thank you very much. It was indeed a very good session, and you have opened our eyes towards newer modalities of delivering anti-cancer chemotherapy into the brain. Thank you very much. I would like to also thank Professor Mukasa for chairing this session as well. I will close this officially now on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito. I would like to thank both the speakers of today, Professor Ali Reza Manzoori and Professor Yu Yao, as well as the chair, Professor Akitake Mukasa, for the time and support for the ACNS webinars. A special thanks to our Vice President, Professor Shubin, for broadcasting this webinar on the WeChat channel. And as he mentioned, we have around 600 people who have joined us live. A special thanks to my co-host Liu Bun Seng as well for joining in today. So until we all meet tomorrow, it is bye-bye from all of us. Thank you very much for joining.